26th webinar, thanks to this COVID era that we have been taken to the virtual and the online classes. And today we have some out of the box training program for you with the theme of heart failure symposia. What is the epidemiology and the current management perspectives in this time? And today we are going to have the first session on heart failure classification and the next one on the heart failure reduced ejection fraction. We have the privilege of having Dr. Neeraj Phalla with us, who's a Senior Director Cardiology from the BLK Super Specialty. We have Dr. Vimit Kumar Jain, who is consultant at the Jaipur Golden Hospital. We have Dr. Ashwin Mehta from Gangaram Hospital, Dr. Amitesh Agarwal from University College of Medical Sciences, and Dr. Vinayak Agarwal, who will be joining us soon. And along with me, I have my colleague, Professor Girish MP from GB Pant Hospital. So over to our chairpersons to start the session. In case you have any questions, any clarifications which are required, please feel free to type your question in the chat box. They will come to us. We'll have a vivid and a candid discussion at the end of this session. So over to you, our chairpersons, to please start the session and invite our first speakers. Yes. Dr. Ashwani, please. Yeah.
You are muted, Dr. Ashwani. You are muted. Okay.
Hello, am I audible?
Yeah,
yes,
please.
You are audible.
Yeah. So, in fact, I just missed, there was some connection interference and I just missed Mohit. What did you introduce and what?
Yeah, I just requesting you to please start the session with our first speaker.
Yeah. In fact, it is a great honor and to be a part of this program. And the first speaker today is Dr. Ambuj Roy, and he is going to speak about the heart failure. Over to Dr. Ambuj Roy.
Dr. Ambuj, if you can share your slides, please. Mudit, in case we have a technical problem with the audio of Dr. Ambuj, I think we straight away go to this.
Yeah. I think there was some technical problem, and in fact, I was not able to speak on this, but now I think this problem has been sorted out. And, you know, this is a great event which is being organized by the CSI Delhi. And our first speaker today is Professor Ambuj Roy, and I have a great opportunity of introducing him. He's a senior cardiologist consultant at AIIMS, New Delhi, and he's going to speak on heart failure classification, epidemiology in India, the patterns and the numbers that we must know. Dr. Ambuj, if I'm audible, you can please start the session now. Over to you, Dr. Ambuj.
Sir, I think Dr. Ambuj is taking time to join. So because of some technical issues, sir, I think we go to the second talk by Dr. J.C. Mohan. So we'll first have the talk on heart failure reduced ejection fraction management in 2020, synthesizing evidence and translating into practice by Professor J.C. Mohan, who is chairman and head of the Department of Cardiology from Jaipur Golden Hospital, Delhi. Over to you, sir, for the session.
Thank you, chairpersons, moderators, and organizers. I, at the outset, express my deep gratitude to Cardiological Society of India, Delhi branch, for having given me this opportunity to interact with postgraduate students of cardiology. I also express my gratitude to Dr. Mohit, who thought me worthy of talking about management of heart failure with reduced ejection fraction. We are going to review the conventional therapy. We would talk about new data on disease-modifying therapy, challenges in initiation of new therapy, and recent guidelines. I need to say I have no conflict of interest. Heart failure is a neurohumorally mediated clinical syndrome of effort intolerance, where there should be structural alteration in the heart, and as a marker of elevated filling pressures, natriuretic peptides are raised. So you got to have symptoms of effort intolerance and possibly signs, structural alteration, and of course elevated natriuretic peptides. We know of the distinct phenotypes which occur in heart failure. Heart failure with reduced ejection fraction, which is by definition less than 40% ejection fraction with syndrome of heart failure, is the dominant variety of heart failure in this country, accounting for 2/3 of all heart failure. The other two today we wouldn't be discussing. From a physician's viewpoint, heart failure is when you pay a higher cost of increasing the cardiac output with effort in terms of left ventricle filling pressure. So normally cardiac output should rise with a minimal increase in filling pressure in all of us who are normal individuals. When the cost is high, we call it heart failure. So what should be the cost? The normal upper bounds of the cost are that for every less than 2 millimeter rise in capillary pressure, there should be pulmonary capillary pressure, 1 liter cardiac output increase should be there. For a pulmonary artery mean pressure, that could be less than 3 millimeter. It got to be less than 2 millimeter. Typically, it is just 1 millimeter mercury, unless people are very elderly, where the wedge pressure rise to cardiac output rise ratio actually becomes 2 millimeter per liter per minute. So we talked about distinct phenotypes, and as I said, our today's discussion is entirely on heart failure with reduced ejection fraction. The other two varieties probably account for 25% of all heart failure in this country. But as we advance further and become more developed, we will have good amount of heart failure with preserved ejection fraction. From a pathophysiological viewpoint, heart failure is a relentlessly progressive, energy-starved, dysfunctional, structurally abnormal and electrically unstable group of cardiomyocytes and abnormal extracellular matrix. And when we talk about syndrome of heart failure, inside the myocardium, there are processes of apoptosis, oncosis, pyrotosis, necrosis, and hypertrophy going on simultaneously. And our aim is to retard all these processes by disease-modifying agents. At the tissue level, what happens initially in initial part of heart failure is the reactive fibrosis, and as disease progresses, you have more of replacement fibrosis, resulting in excess of extracellular volume, excess of fibrosis, and consequently, there are parameters on echo as well as MRI which become abnormal. This is something which Dr. Ambuj Roy was going to talk, and I think he would talk in great detail. 2% of the adult population has heart failure, but heart failure is predominantly a condition of aging, and above the age of 80 years, 14% of the entire population has heart failure. Heart failure in India, we believe at least 1% of the adult population, unlike world where it may 2%, we still may have 2%, could be more, but let us presume the lowest estimate is 1% of the adult population. Taking that in consideration, there are 10 million individuals with heart failure in India, 2 million are added annually, annual mortality is close to 20 to 25%, and as I said, HFrEF accounts for 2/3 of heart failure. Guideline-directed medical therapy is abysmal, less than 50% under all circumstances. half our patients have diabetes, 10% have organic valvular heart disease, and 70% of patients have ischemic heart disease, and about 30% have chronic kidney disease. However, heart failure with reduced ejection fraction patient different in India. We have younger patients, we have more ischemic heart disease, we have more diabetes, we have lesser atrial fibrillation, we have more valvular heart disease, we have more iron deficiency, we have higher mortality, our device use is abysmal, is closer to 2%, and we have less number of heart failure specialists in the society. But keep in mind one thing, that heart failure is a malignant disease. Data from Trivandrum Heart Failure Registry says 3-year mortality is 46% for heart failure with reduced ejection fraction. Once a patient of heart failure has been admitted to the hospital, then it is post-acute decompensated heart failure, and this is a different malignant phenotype. And there is a very recent data published from Vellore Heart Failure Registry in Indian Heart Journal, which suggests that once hospitalization has taken place for decompensated heart failure, rehospitalization within 6 months is 42%, and 6-month death rate is as high as 38%. So one lesson, Dr. Mohit Gupta said, give take-home messages for the postgraduate students. So the first take-home message is hospitalization marks a fundamental change in the phenotype and natural history of heart failure. The heart failure, which is ambulatory, has an annual mortality of 6-7%. It jumps to 25% at least the moment there has been one hospitalization for heart failure. So change in phenotype occurs with the hospitalization. That is first take-home message. So here is the data again from Trivandrum Heart Failure Registry, Indian data, which says hospitalization for heart failure triples the risk of mortality. That is, looking at 1-year mortality, those who never got admitted have it close to 10% mortality. It becomes 30% with one hospitalization. The other interesting thing which has come out from the Vellore Heart Failure Registry, it may not be representative of the entire country, but it tells you the trend, and we need to keep that trend in mind, that post-discharge heart failure is a malignant phenotype. In hospital, mortality is 13%, but heart failure mortality progressively rises. The first month is 27%, 3 months 33%, and 6 months 38%. And this is also the reason, the reason probably is that only 42% of the patient had guideline directed medical therapy at discharge. So we definitely have a vulnerable period immediately post discharge, essentially first 30 days or first 3 months, where the mortality is nearly 5 to 6 times compared to an individual who has never been hospitalized. And we need to aggressively cover this period with all the drugs which can reduce mortality and rehospitalization. We believe in echo in every patient heart failure. These are the minimum criteria which we need in evaluation of heart failure with reduced ejection fraction. And these are important because each of these not only have diagnostic significance, but it has therapeutic significance and prognostic significance. So we need left ventricular ejection fraction volume, the evidence of segmental wall motion abnormality, LA volume, degree of MR, PA pressure, the LV filling pressures, longitudinal strains of left ventricle, left atrium, and right ventricle. But this was the preamble. Focus in heart failure with reduced ejection fraction after you have diagnosed with the help of everything which includes an echo, natriuretic peptides, and clinical examination, and with biochemistry which tells you whether this metabolism playing a role in pathogenesis of heart failure. Our focus is on management. We have 3 aims: reduce high mortality, which I showed you just from India, reduce rehospitalization for heart failure, which again I showed you from the Vellore Heart Failure Registry, and improve quality of life. An ideal heart failure therapy is one which improves intrinsic structural and functional cardiac abnormalities, causes reverse remodeling, That means the LA and LV size decrease and HFrEF fraction improves. The other point is improved skeletal muscle function, efficient mitochondria, and third, it improves the level of natriuretic peptides, which means stretch is reduced and natriuretic peptides go down. If all three are met in large trials, the drug becomes a class 1. And if one or two, if the first one is not met, the other two are met, it becomes relatively class 2. If none of these are met, then the drug may be useful in heart failure, but it may still be a class 3 agent by and large. So impactful therapy is right in the center, and that is you need to decongest these patients with diuretics, you need to have comorbidity control, salt and water, anemia and iron deficiency need to be tackled, nutrition has to be proper, and of course you need help on nutritionists. Remember, you need a multi-team approach to treat heart failure. Vaccination for flu, hepatitis, and pneumonia needed. Palliative care may be needed at the end of life. We need more heart failure specialists. We may have to fix up mitral regurgitation, fix obstructive sleep apnea, use devices, oral anticoagulant for atrial fibrillation, revascularization. Having said that, the four corners of therapy are anti-RAS agents, including ARNI, beta blockers, mineralocorticoid receptor antagonists, SGL2 inhibitors as drugs, and important thing is devices, both ICD and CRT in suitable cases. And on side of this hexagonal, I have tried to show two drugs which have a class 2 indication, Digitalis and Ivabradine. And we need to keep in mind that this all forms the core of heart failure with reduced ejection fraction therapy. And the other things we need to remember always, and Dr. Mohit, as I said, asked me, give key messages. Remember, as a postgraduate student, remember these 4 words. You need to evaluate every patient, intensify treatment till you reach the maximally tolerated dose, switch may be required actually from ACE inhibitors to ARNI, switch may be required from potassium-losing diuretics to potassium-sparing diuretics, and you need to periodically review not only the patient but also the therapy. Stable on diuretic dose is not a good thing, but patients should be stable both on diuretics and neurohumoral modulating agents. Diuretics are needed, but too much of diuretics are not good at the cost of disease modifying agents. We also have understood one thing, that diuretics do decrease hospitalization for heart failure and may have a trend towards reduced mortality. So we will talk about the drugs, the new drugs upfront in heart failure with reduced ejection fraction with quantity of evidence, quality of evidence, and risk-benefit ratio. But before that, let us take you through the journey of heart failure with reduced ejection fraction till 2014. We had initially thought of heart failure in 70s as a hemodynamic syndrome, and we used Digitalis and diuretics. Then we added, actually, we thought it's a neurohumoral syndrome. We added anti-RAS agents and beta blockers. 2010 onwards, we have been regularly using anti-RAS agents, beta blockers, mineralocorticoid receptor antagonists, and Ivabradine. And of course, now in 2014, we added ARNI in place of ACE inhibitors. So from hemodynamic modulation, which we did nearly 50 years back, we have moved to complete neurohumoral modulation in patients with heart failure with reduced ejection fraction. The end result has been progressive decrease in annual mortality as we have moved from left to right. But the randomized trials have shown a remarkable decrease in all-cause mortality, starting from 22% SALT trial, SALT prevention trial, SALT placebo arm, to something like 6.5% in the current trials. However, this is not reflected in the community management of heart failure, where mortality continues to be pretty high. And if we want to reduce mortality, as shown on the left side, by giving the triple therapy, we need to keep on adding these bricks. the bricks of MRA, ACE inhibitors, beta blockers, and ARNI. All of these actually would produce consequent and significant sequential reduction in annual mortality. And we need to keep in mind that suboptimal therapy doubles the risk of mortality, and the optimal therapy definition, which could be anti-RAS and beta blockers, has been changed, and currently it probably would include 4 different classes of drugs which we will be discussing. But adherence is another important thing to guideline-directed medical therapy, and people who have good adherence have a mortality which is 2.5 times less than those who have poor adherence. So, what kind of therapy we use in heart failure? We reduce ejection fraction. As I said, drugs. These are the molecular solutions or biological solutions to a problem, a pathophysiology problem. We have rhythm therapy with ICD to prevent sudden cardiac death and CRT to produce resynchronization, and we have mechanical solutions in the form of LVAD and heart transplantation at end of the end stage heart failure. And of course, all these things have to be seen in right perspective. Drug treatment of heart failure will reduce ejection fraction, symptomatic relief, and disease modifying agent. Both are required. You cannot do away with one of these, but the fact is relying only on symptom relief drugs like diuretics, digoxin, nitrates, inotropes, and ivabradine is a bad idea. You must have a judicious mix of symptomatic relief drugs and disease modifying agents, which are anti-RAS agents, beta blockers, MRA, ivabradine. Ivabradine features at both places, ARNI and SGLT2 inhibitor, which are the new kids on the block for management of heart failure with reduced ejection fraction. How to maximize the background guideline-directed medical therapy to lower the risk for disease progression? You can have a step care approach, start with A, go to B, then you can go to MRA, then you can go to maybe ivabradine in suitable cases, and then SGLT2 inhibitors. You can also have a sledgehammer approach. Nobody says which approach is better. Currently, more and more people are pushing towards sledgehammer approach, which means start all drugs within a short span of time. Within a week or two, you should start all the disease modifying agents. Now, that is a radical approach compared to a step care approach where you tend to add one drug, go to the maximum, then add another drug, and that will take several months. And during this time, a lot of people will drop dead or be re-hospitalized. So I personally prefer a sledgehammer approach where within the shortest period, you try to give all the disease modifying agents looking at the caveats. Talking about diuretics, there isn't any doubt that diuretics for symptom relief for congested patients is a class 1 indication. However, our problem is how to determine optimal euvolemia, and that remains a major challenge. You can have clinical congestion, which you can see by JVP, liver, RAL, speedal edema, and if these disappear, that doesn't mean that the patient is decongested. You still can have hemodynamic congestion, and this occult congestion is a major source of rehospitalization, and that is why more and more people are suggesting use of non-invasive methods like echocardiography, use of natriuretic peptides, or use of sensors to put in pulmonary artery to measure pulmonary artery pressure, to evaluate hemodynamic congestion and take care of it. Obviously, if you take care of hemodynamic congestion, as has been shown in CHAMPION trial, you probably would reduce to some extent mortality also with diuretics. At least there would be a trend towards reduced mortality. However, we need to keep in mind the downside of diuretics, and that is why do not exceed the desired dose. The diuretics have all benefits. They are good, they are bad, and they are ugly. They are ugly when you are using excess dose of diuretics, which produce RAS activation, SNS activation, and worsening renal function, besides dyselectrolytemia. So diuretics remain class 1 agent. However, you need to look at both clinical and hemodynamic congestion critically to decide what should be the right dose of diuretics. Talking about digoxin, which is again a 150 years old drug, it has a class 2B indication for worsening chronic heart failure in sinus rhythm. It is grossly underutilized and underrated. From previous trials of mid-90s where 70% patients were on digoxin, current recent trials, DAPA, HF, and EMPEROR reduced, the use of digoxin has fallen to 25%. But keep in mind, and the reason is obvious, digoxin has a narrow therapeutic range. All-cause mortality shows a bimodal effect. Up to 1 nanogram per ml serum level, mortality is reduced. The moment level increases 1 nanogram, mortality increases. And there are a host of drugs which are causing interaction and digoxin levels can rise. And this is one of the reasons physicians just don't like a drug which has a narrow therapeutic range and where they have to remember all the drug-drug interactions. But digoxin should be considered in patients with HFrEF who remain symptomatic despite optimal medical therapy because it is a cheap drug. Just to remind you that this is data from the Digitalis investigating group looking at cardiovascular death and hospital for heart failure. There was a significant 17% reduction in primary endpoint, but this endpoint was largely because of reduction in hospitalization for heart failure. Cardiovascular mortality with Digitalis is not affected, but hospitalization for heart failure reduced, more so in HFrEF, little less in heart failure mid-range ejection fraction, and of course the least in HFpEF. Digoxin works very quick. Within 30 days, you can reduce the hospitalization rates by 34%. So keep in mind one thing, that if the patients are symptomatic, before you go to these drugs which you can call as fancy drugs like SGLT2 inhibitors and ARNI and of course other drugs, think of Digitalis in appropriate dose with close monitoring. Low is a drug which reduces hospitalization for heart failure remarkably in good number of patients. Coming on to disease modifying agents, here are the disease modifying agents. You could divide the drugs into 5 classes: anti-RAS agents, which also reduce mortality, beta blockers, aldosterone antagonists, ARNI, and finally SGLT2 inhibitors. And I have taken example of DAPA-HF trial just to show that all these 5 classes of drugs reduce all-cause mortality and also reduce hospitalization for heart failure, as you would see in extreme right column. And number needed to treat is actually very, very acceptable, all below 25. The ACE inhibitors are the first drug which most of the people use. The guidelines say start the therapy with ACE inhibitors. Treatment, the effect of the treatment comes very early, and this is data from SOLVE trial showing that mortality at 12 weeks reduced by 32% and hospitalized for heart failure by 48%. So the lesson, the take-home message is start ACE inhibitor, go to the maximum dose as quickly as possible, because this is a wonderful class of agents. We have enormous amount of data with ACE inhibitors showing reduction in mortality, and we can look at consensus 2 and SOLVE trials, an example where there has been a significant 27 and 16% reduction in all-cause mortality. Guidelines have given ACE inhibitors class 1A indication and ARB as class 1B indication. In ACE intolerant patient, you can use ARB. The beta blockers also have a class 1 indication along with ACE inhibitor or ARBs or ARNI. But why are these drugs disease modifying? Because the data from SOLVE trial shows reverse remodeling with enalapril. There is increase in ejection fraction, average about 4%, and decrease in left ventricular end diastolic volume. That is what is called reverse remodeling. Decrease in volume and increase in ejection fraction. But ACE inhibitors must be given to the maximally tolerated dose. This is based upon this 20 years old study called ATLAS, where low dose versus high dose lisinopril was compared in HFrEF, and events were 20% less. Both cardiovascular death and hospital for heart failure were 20% less in patients who were given high dose, maximally tolerated dose, rather than the low dose. Beta blockers are the number 2 drugs, and they are again class 1 agents. People tend to initiate after ACE inhibitors. I would suggest to start both of these simultaneously because beta blockers normally don't lower blood pressure, and they are great drugs to start in combination. Combinations are available, whether you use carvedilol, metoprolol succinate, or you use bisoprolol. All these drugs produce a 35% reduction in all-cause mortality with significant reduction in hospitalization for heart failure. Data from optimized HF registry again suggests that the effect comes very early. If you look at the addition of carvedilol to treatment, mortality reduction of as much as 50% comes up within the first 2 to 3 months. Again, the take-home message is you must start beta blockers as early as possible because otherwise you lose many people who would otherwise die. The beta blockers unfortunately don't seem to work that well in atrial fibrillation, and you need to keep that in mind. The data from all the beta blocker, 4 big randomized trials suggest that if the patient has atrial fibrillation and HFrEF, there is no benefit for hospital for heart failure and mortality, and all benefit in those with sinus rhythm. It doesn't make a difference whether you're giving high dose beta blockers or low dose beta blockers. What is important in achieving a heart rate below 70? Because regardless of the dose of beta blockers, every 5 beat decrease in heart rate reduces the all-cause mortality by 18%. So if you can achieve a heart rate below 70, and ideally between 60 and 70, it doesn't matter which dose of drug you give. And this is also the reason why ivabradine is popular in treatment of HFrEF, because if you are not satisfied, you can't bring down the heart rate below 70. Ivabradine always available to do that in sinus rhythm. And again, beta blockers bring up that change as quickly as possible. In fact, the data from Copernicus study says that within 3 weeks, you start seeing a reduction in mortality. In fact, within 8 weeks, there can be a very large reduction in mortality of 80%, again suggesting that you should start beta blocker the moment you diagnose heart failure. Try to up titrate as quickly as possible to get the heart rate below 70. Here in Copernicus trial, the data suggests that the benefit with regard to mortality comes within first 3 weeks. And in case you cannot achieve the heart rate reduction with optimally doses of beta blocker for whatever reasons, and patient in sinus rhythm, the best thing is to bring down the heart rate by other means, and other means includes ivabradine. Reason, this is a large data published few years back looking at the inflection point at which increasing heart rate increases mortality, and inflection point is 75 beats per minute. So this registry, get the guidelines registry says that if case heart rate is above 75, bring it down, use beta blocker alone, use beta blocker plus ivabradine, or if beta blockers are contraindicated for whatever reason, sinus rhythm, use ivabradine to bring the heart rate below 75. The data for ivabradine came from HFrEF trial conducted by Carl Swedberg from Sweden, and it showed a 18% relative risk reduction in patients who were on optimally controlled with beta blocker, but still their heart rate was above 70. And because of this reason, ivabradine has a class 2A indication for management of heart failure with reduced ejection fraction. Remember, these patients had a heart rate of 80 beats per minute and were brought down to something like 70, which resulted in significant 26% reduction in hospital for heart failure, but no significant change in cardiovascular mortality. You can use ivabradine even in those patients who are not on beta blockers. There, the benefit can be large. So the drug is also suggested for those people who are not on beta blocker. It is a class 2B indication because the benefit is nearly twice in those who are not on beta blockers compared to those who are on beta blockers. Again, the benefit comes up very quickly, suggesting that you must start the therapy to reduce heart rate as quickly as possible. You can't be waiting for several weeks to bring down the heart rate below 70. The data from SHIFT trial again suggests that within 30 days of starting ivabradine, you can reduce the chances of hospital for heart failure by 30%. And hospitalization, costly and deadly, we have already discussed, and that is why you need to bring down the rate as quickly as possible. The ACC consensus guidelines suggest that you should try to achieve the target dose as quickly as possible. More so with beta blockers, you should optimize guideline-directed medical therapy, but you must modulate heart rate below 70. Whether you use a beta blocker approach or non-beta blocker approach is up to you, but try to get it as quickly as possible. I wouldn't be talking about isosorbide dinitrate and hydrogen combination, which is of course a class 1 indication in blacks. And a lot of people believe that we have genetic makeup like blacks, we might benefit from ISDN and hydrogen. Unfortunately, we have no evidence, and in the absence of evidence, I don't want to talk about this drug, except saying that people who have hyperkalemia, you can't use anti-RAS agents. Maybe you can try this drug, but then we have better drugs available. Actually, we have drugs like the drugs like SGLT2 inhibitors, which have a far bigger benefit. When to use ivabradine? Of course, beta blocker resistance, beta blocker intolerance, and as a bridge therapy when the blood pressure does not allow large dose of beta blockers to be used. You should use as a combination with ivabradine, and then gradually you can withdraw ivabradine. We come to mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonists have been studied in three big trials, RALS, EFSUS, and emphasis HF. And the gist of these three trials is that in HFrEF, these reduce mortality, cardiovascular mortality, all-cause mortality, and hospitalization for heart failure at least twice more than they do in patients with HFpEF. Because of these reasons, after ACE inhibitors and beta blockers, these are recommended class 1A agents for management of HFrEF. And as I said, I use a sledgehammer approach where MRA should come up very quickly within the first few days of having detected heart failure or patient ready for discharge after ADHF. The emphasis HF trial, which used eplerenone, showed a 37% reduction in cardiovascular death or hospitalization for heart failure in patients who were class 2. They were mildly symptomatic. You might say, well, if the A and B are working, should I give MRA? Should I give eplerenone? There is a large amount of data to suggest mildly symptomatic patients have benefit from MRA. So another lesson, as Dr. Mohit said, with the lesson is MRA must be given to all patients of heart failure with reduced ejection fraction unless rising serum creatinine or hyperkalemia do not allow you. Regardless of whether they are mildly symptomatic, moderately symptomatic, mineralocorticoid receptor antagonist must be given, and they should be initiated as quickly as possible. Data by Alan Mazel in the form of a study called COACH study has shown that within 1 month, there is event reduction of 45% if you give MRA compared to those who are given MRA after 1 month. So the moral of the story is start as quickly as possible. How quickly? Well, here is actually, so these are some of the benefits we are talking about: all-cause mortality, cardiovascular death, and even sudden cardiac death is reduced significantly with eplerenone. Many of these patients would no longer be candidate for ICD in case you use appropriate doses of MRA. MRA effect, again, as I said, those who develop hypokalemia with diuretics, loop diuretic, they get far greater benefit with MRA compared to those who do not develop hypokalemia. There also it is very impressive, 31% benefit. But if you have used loop diuretic, you see a person with hypokalemia, remember, this is a patient who absolutely needs MRA because this patient is going to have huge benefit. When to start, as again I said, let us look at the EFSUS study. These are post-MI heart failure patients. the benefit is largely confined to people who are given eplerenone within 7 days of discharge. If you start MRA later on, there is hardly any benefit in post-MI heart failure. So keep in mind, remodeling is very fast in post-MI heart failure. You can't be waiting for MRA to be started after several weeks. All you have to do is, before discharge, you need to start this drug. And if you start early, you can reduce sudden cardiac death by 35%, vis-a-vis no effect on sudden cardiac death in case you start after 1 week. So keep those things in mind. This lesson I'm emphasizing because Dr. Mohit Gupta said, you must give a take-home message for everything you are saying. We now talk about ARNI. We know that angiotensin actually is a vasoconstrictor. We also know there is a enzyme called neprilysin which breaks down the vasodilatory molecules, and that produces double whammy. If we have a drug which will actually take care of angiotensin 2 and also be an inhibitor to neprilysin, that would be a wonderful drug for HFrEF. And ARNI or Sequel or sacubitril valsartan is one such drug. So ARNI or sacubitril valsartan is a unique molecule, is a multi-modulator molecule, is an anti-RAS agent like ARBs and ACE inhibitor, increases the BNP, it increases the GLP, it increases cyclic GMP, which improves the myocardial relaxation and vascular relaxation. Because of these effects, you have better vasodilation, better natriuresis, better diuresis, reduce apoptosis, reduce hypertrophy, and reduce fibrosis. And the landmark paradigm HF study conducted and presented by John McMurray in 2014 showed a 20% reduction in cardiovascular death or hospital for heart failure over and above enalapril when ARNI was used in a randomized double-blind fashion in patients, those who were on 93%, those who were on beta blockers, 57% on MRA, and device use was there in nearly 1/4 of these patients. Clearly, compared to ACE inhibitors, ARNI scores over in every aspect. Both cardiovascular death and hospitalized for heart failure were significantly reduced. Sudden cardiac death was also reduced by 20%. All-cause deaths were also reduced by 16%. And the effect comes up very quickly. As I said, within 30 days, there was 38% reduction hospitalized for heart failure. Important thing again, like ACE inhibitor, like Atlas trial, dose matters. Those people who have sustained target dose have much less events compared to people whom where you have done any dose reduction either arbitrarily or because the patient could not tolerate the drug. The difference is 2.5 times. Sequel also actually in post-ICD patients of heart failure reduces ventricular tachycardia, shock, and sustained ventricular tachycardia, clearly indicating that there will be a large number of people who not only may not require actually ICD, but the shock given by ICD may be required much less, and you may not require additional antiarrhythmic drugs. This is because the drug is again disease-modifying agent. It improves the ejection fraction in this randomized double-blind and single-blind controlled trial, IMPROVE-HF trial of 800 patients, about a 10% increase in ejection fraction once you switch from ACE inhibitors to ARNI. So ARNI causes reverse remodeling in a time-dependent manner, and as the time passes, by 12 months, you have nearly 10% improvement in ejection fraction. So comparing ACE inhibitor with ARNI, all-cause mortality reduction is double, cardiovascular mortality reduction is double, and sudden cardiac death mortality is 4 times better with ARNI compared to ACE inhibitors. That's why the guidelines given class 1B recommendation to shift all class 2 symptomatic patients from ACE inhibitors to ARNI, and use of ARNI has been tried across all the disease spectrum, including chronic heart failure, post-ADJ patient, and quick dose escalation, and of course, reverse remodeling has been shown. Recent observational study has shown in SAVE ICD that the shocks given for ICD and theoretically ICD use can be brought down by 25%. consensus guidelines by ESC suggest that when you are discharging a patient with or you are a new onset heart failure or acute decompensated heart failure, you can start therapy with ARNI straight away rather than ACE inhibitor or ARB. And as I said, the SAVE ICD study has shown that 25% of patients may not require ICD in case you start ARNI well on time. Predictors of successful initiation of SACWEL are younger age, higher blood pressure, prior hypertension, no atrial fibrillation, and EGFR above 60. So currently, ARNI plus beta blocker per MRA are the best combination to reduce mortality in patients with HFrEF compared to other drugs. Now we come to SGLT2 inhibitor, new kid on the block. We still have to get recommendations by the guideline committee, but the impression is very strong that these will become class 1 agent as soon as the guidelines are revised, and we need to discuss this issue. The randomized control trials, the 3 trials with SGLT2 inhibitors, the EMPA-REG outcome, DECLARE, and CANVAS showed in secondary or exploratory endpoint that cardiovascular death and hospital for heart failure are reduced significantly by 23%. To test this hypothesis, 2 trials have been done, one called DAPA-HF, where in HFrEF, dapagliflozin has been compared to standard of care in both diabetic and non-diabetic individuals, and dapagliflozin has shown a 26% impressive reduction in cardiovascular death or hospital for heart failure or emergency visits. And the drug therapy is equally effective in diabetics and non-diabetic, suggesting that this drug is going to become a class 1 drug when guidelines are revised. The other drug, the empagliflozin, presented just about 1.5 months back, showed a similar kind of 25% reduction in primary endpoints when empagliflozin was used in HFrEF patient who had standard of care, best of the standard of care, rather I'll say more than 90% were on anti-RAS agents and beta blocker. Half of these were diabetic, half non-diabetics. So SGLT2 inhibitors on top of standard of care therapy in HFrEF, when you compare DAPA-HF and EMPEROR reduced trial, similar kind of overall primary endpoint reduction, similar kind of hospital for heart failure reduction, some difference in cardiovascular deaths, but there is no heterogeneity, and both drugs would reduce cardiovascular deaths. We don't discuss the mechanism underlying the SGLT2 inhibitor advantage. These could be diuretic or hemodynamic benefits, myocardial energetic benefits, or hematocrit hypothesis, but we are discussing lots of hypotheses. Doesn't make a difference. So long a drug is effective, the mechanism, 1 or 2, do not make a difference. So the question is, should you give SGLT2 inhibitors simultaneous with the AB and MRA or sequential? Which is the right sequence and optimal time, and all should be on board? And I said, most people believe that all these 4 drugs should be on board within 8 weeks. My approach is a sledgehammer approach. As quickly as possible, patients should be on board with anti-RAS agents, which actually preferentially ARNI, beta blockers, MRA, and SGLT2 inhibitor, regardless of presence of diabetes or not. Reason, where we have very recent data which suggests that when you used SGLT2 inhibitors and ARNI, you produce further 50% reduction in mortality compared to use of anti-RAS agents and beta blockers alone. And you add 6 years to life for a middle-aged person who has heart failure. Despite that, the therapy is underused and underutilized. This is Asian Heart Failure Registry showing gross underutilization of doses of ACE inhibitors, beta blockers, and MRA. We also need to shunt the enthusiasm exceeding evidence, and that is why I strongly suggest, again, a take-home message. There is no benefit of statins, coenzyme Q, trimetazidine, ranolazine, carnitine in heart failure. All studies are small, inconsequential, with conflicting results, and I would suggest that unless statins are required for ischemic heart disease, other agents should not be used in HFrEF. Monitoring the progress of the heart failure patient, you can use it clinical heart rate, blood pressure, dyspnea, body weight, body temperature, and of course, periodically, maybe every 3 months or 3 to 6 months, you should look at natriuretic peptides, electrolytes, serum creatinine, ferritin level, and of course, procal. So in the end, I must say that besides drugs, You must educate your patients, build teams, multidisciplinary team, improve the decision quality as far as the HFrEF management is concerned. So, ladies and gentlemen, to summarize, taking failure out of heart failure is going to require resources, is going to require vision, and is going to require evidence-based therapy in an optimal, sustained manner. War is far from won. Journey of heart failure long and arduous, but we are getting there. Thank you very much.
Thank you so much, sir, Dr. Mohan, for such a lucid talk on heart failure with reduced ejection fraction. I would now like to invite Dr. Ambuj Roy to deliver his lecture. He is a senior professor of cardiology from All India Institute of Medical Sciences and a dear friend. And Dr. Ambuj, you can start your lecture.
Thank you, Girish. And I think the Murphy's law never goes wrong. Whenever things have to go wrong, they will. I mean, so I'm sorry for this not being able to deliver first. And I will just, so my task was to talk about heart failure classification and epidemiology, as much data with emphasis on India where data is available and what the patterns and numbers are. So I'm glad, Mohit, and you have brought this up in a PG track. Conventionally, non-valvular heart failure has never been the emphasis in a PG exam, for example. But I think that will change already. We have now a format where we discuss practical cases. And anyway, even if it's an exam or no exam, to be an optimum cardiologist today, you must know things about heart failure. And a lot of it has been spoken about by Dr. Mohan. But my task was to talk about the epidemiology. So I framed these 5 questions that a PG student should know to as part of his completion of his training, and that is something which he may be grilled on in his viva too. So how do you diagnose heart failure? Obviously, somebody coming into an CCU, there is no brainer. But in an OPD or an epidemiology study where you have to do for heart failure, how do you diagnose heart failure? And that is something which has been conventionally used, is the Framingham diagnostic criteria for heart failure has always been used for this. It has the major criteria and minor criteria. I'll not go into the details, but it would be good for you to know what are the major and the minor criteria are. And like most things in cardiology, you need to have either 2 major criteria to diagnose heart failure, or you need 1 major and 2 minor criteria. But as you can see, pulmonary edema, hepatojugular reflux, neck vein distension, PND. So these are obviously very advanced heart failure patients. And so this diagnostic criteria is not very sensitive. And the ESC criteria is far more modern, I would say. And they basically look at the clinical history, whether there is a fertile ground to have heart failure, like presence of CAD, arterial hypertension, whether there is a use of diuretic and symptoms like orthopnea and PND. Then it looks at physical examination and then looks at any abnormality on the ECG. And if you have one of these, if you have none of them, heart failure, very unlikely. But if you have one of them, it advocates you use natriuretic peptides, which I think have now become the cornerstone for heart failure. It's like ECG and MI. Natriuretic peptides are now the cornerstone for diagnosis. So you do that and confirm your diagnosis of heart failure. And then, as mentioned, 1 baseline echo must be done to get your etiology of heart failure, the type of heart failure, which I'll discuss, and as far as possible, then you go ahead on managing these heart failures. So that's how you diagnose heart failure in cases where there is a doubt, as I said. What are the stages of heart failure? Again, I would say here there is 3 systems which work. which have been summarized very well in this slide, I would say. One is the kind of epidemiological definition. Second, I would call a clinician's definition. And third, I would call a heart failure specialist's classification. So the broad macro view is on the stages of heart failure, stage A, stage B being pre-heart failure conditions, pre-symptomatic conditions, which are grounds for developing heart failure in the future. Stage C is where you have heart failure. Stage D is where you have refractive heart failure. And a bit of a burden of this we will discuss, and why it is important to know these stages for anybody practicing cardiology. And then we have the classical NYHA class, which comes in, obviously it kicks in only when you have stage C. So then you have four classes, as you all very well know. But then in advanced heart failure, you need further classification, because you need to go for advanced therapies like LVADs and other mechanical circulatory support, or like heart failure therapies. So for them, there is the intermax classification. Again, something which is not often taught, but I must say that all of the students should be very well aware of this classification. And it is again divided into class 1 to 7. Unlike NYHA class 1, it's the reverse of NYHA class, where 1 is the worst class, which is, and all of them have a very nice nickname. So 1 is where you are in severe cardiogenic shock, called the crash and burn stage, to stage 7, which is class 3, and it is somebody who is class 3, but but has going towards severe heart failure. So this is something which we should know, and how you should manage them. Coming to the burden of heart failure, so stage A, stage B, as I said, stage A is essentially when you have risk factors for heart failure like hypertension, diabetes, metabolic syndrome, alcohol abuse, and coronary artery disease. Stage B, where you have LV dysfunction but don't have clinical heart failure. So what is the burden of this stage A? And as you can see here, I mean, the burden is in our country is huge. Hypertension, more than 21 crore people living with hypertension, more than 7 crore people living with diabetes, pre-diabetes. Ischemic heart disease burden is more than 6 crores. And rheumatic heart disease has somewhat come down, and 2 to 2.5 million people. But from our survey, which we have done in both rural and urban Delhi, if you can see here, the various risks for which are classified in stage A of hypertension, stage A of heart failure, like overweight, hypertension, diabetes, they are remarkably high and have increased in the last 2 decades substantially. So very high the prevalence of obesity, overweight, very high hypertension, 42% urban people were hypertensive above the age of 30, and very high diabetes, 1 in 5 above the age of 50. Even the rural parts have seen a substantial increase. So obviously there is very fertile grounds for future heart failure. Unfortunately, we manage our risk factors very poorly, and that's why we are seeing an increasing burden of heart failure patients coming to our hospitals. So this is a classic review of all the hypertension studies by Anchala, and they clearly showed that our control rates are pretty abysmal. Rural India having hypertension control rates only of 10% and urban of 20%. And if I make some calculations based on the number of hypertensives that we have almost 165 million people who have hypertension which is not controlled. And why is this important? Because it's clearly known there is a linear relationship between hypertension, years you live with hypertension, and heart failure. In fact, if you see all the trials, the biggest impact that hypertension management has is not on CAD or stroke, but on reduction in incidence of heart failure. And from the HFrEF trial, indapamide without perindopril showed a 64% reduction in failure hospitalization in the elderly when they managed, when they were treated for hypertension versus if they were not. And similarly in HFrEF trial, the classic HFrEF trial, 54% reduction in heart failure was seen incidence was seen over 4.5 years. So if we just make a back of envelope calculation with 200 million hypertensives in India, if we manage these patients adequately for their hypertension, and HFrEF did not have a very stringent hypertension targets like what we have today, even then we would reduce 4 million patients from developing heart failure in India. So that is the kind of impact this risk factor burden has. It's a no-brainer now that, and you all must be seeing in practice, every third patient is a diabetic in a cardiology clinic, and our burdens on diabetes have increased significantly over the last 2 decades, as seen here from the global burden of disease maps. And similarly, diabetes management also reduces heart failure incidence, and this is from the classic UKpedia study that showed that 1% reduction in HbA1c could reduce heart failure incidence by 16%. So obviously we need to do good in managing a stage A so that they don't go on to stage C, stage D, which is, you know, very resource intensive, and in low resource settings like ours are very difficult to manage. So what about the burden of stage C, stage D heart failure? As mentioned by Dr. Mohan, the prevalence of heart failure broadly in developed world is 1 to 2% in adults, and it goes up to 10% in those above 70 years of age. And as you can see here, it's clearly climbing up the blue bars, the pink bars as age goes up. And amongst those above 65 years of age, if you see actually 1 in 6 person coming with breathlessness can have HFpEF. So elderly, again, HFpEF becomes very common. And the lifetime risk of heart failure at the age of 55 right now is 33% in men and 28%. Like 1 in 4 women would go on to develop heart failure at the age of 55 and 1 in 3 men. Worldwide prevalence of heart failure is supposed to be 64 million. And conservative estimates show that the heart failure burden is about 4.6 million in India. But I think this is very much underdiagnosed and based on studies which have not given the real true picture. Because as I said, heart failure is not easy to diagnose, and we miss a lot of cases of early heart failure. So what are the types of heart failure that you should know? Of course, this is the classical definitions of heart failure, which is HFrEF and HFpEF, and then the new kid on the block, the heart failure with mid-range EF, which was formally put into the guidelines in the 2016 ESC guidelines, which is a bit of mix between features of both types of heart failure. But these are the current definitions of heart failure. But there is a little more that you should know about HFpEF diagnosis, and this has been very well given by the Heart Failure Association of ESC, the PEFF diagnostic algorithm. I will not go into the details for the, because I know we're running behind schedule, but it is something that you should know, and this is something that will possibly be asked of you. So the PEFF guidelines suggest you do a pre-test assessment, then you do the diagnostic workup, which is the cornerstone of diagnosing HFpEF. That is a good echo and a nitriurate peptide score, which I'll just show you what they are. And then you have advanced workup with a stress test or a hemodynamics in those few patients who are not who are intermediate scores on the diagnostic workup in the second step. And then, of course, is the advanced etiological workup if you don't have this. So the scores are, again, a major and minor, and major gets 2 and minor gets 1 point. And it's based on the functional and the morphological features on the echocardiography and the biomarkers. And the cutoffs here are different for sinus rhythm and atrial fibrillation. Obviously, it's higher for atrial fibrillation. And this is something that, again, you should know. And a score of 5 or more gives you a diagnosis of HFpEF. But if it's less than 2, then you rule out HFpEF. And between 2 and 4, as I said, you need to do more advanced diagnostic workup in terms of either a stress echo or you go for invasive hemodynamic measurement. So this is again something that all of you should know, the diagnostic workup of HFrEF, which is important from your point of view. In terms of the burden of the types of heart failure, if we see, so again from Western studies, if you see classically HFpEF is the one which has been increasing in burden, and almost 50% is the distribution of HFpEF and HFrEF in the Western population. However, in India, the both two large studies, the INTER-CHF and the Trivandrum Heart Failure registry, show a much lower prevalence of HFpEF as compared to HFrEF. There could be multiple reasons for it. One is the younger population. Two, we may not be picking up as many HFpEFs because, as I said, it requires a bit of investigative workup, and a lot of patients were maybe just living with the dyspneas diagnosed as deconditioning or diagnosed as COAD, and they may actually be having HFpEF. But the data shows that between 20 to 25% the HFpEF prevalence among the heart failure population in India. For the acute types of the acute decompensated heart failure, again, you need to remember this classification given by the 2016 ESC guidelines. Broadly, it is in two types: congestion plus or congestion minus, and hypoperfusion plus or hypoperfusion minus. And based on that, you're defined as warm dry, which means no congestion, which means basically no hypoperfusion but with congestion, and warm wet, cold wet, or cold dry. And obviously, the worst are those with both congestion and hypoperfusion. And it is an important prognostic marker also of the patient with acute decompensated heart failure. So this is again something that you should know about the types of acute decompensated heart failure and how to classify it. And coming to the last part is the outcomes of heart failure patients and its evolution. So what is the prognosis of heart failure patients? And if you were asked this question in your exam, you could actually smartly say depends. And if your examiner is, accommodative, he would understand it. But yes, you need to tell us why heart failure outcome depends. And it really varies because it's a very heterogeneous disease. You can't club it together. But if you have to, this is one of the best analysis of all heart failure studies put together, where they excluded, remember they excluded ADHF, which, as Dr. Mohan correctly mentioned, is a separate disease, has a very bad prognosis of 50%, almost 30% mortality at 1 year. Excluding that, people with so-called stable heart failure, if you see, your 1 year mortality is almost 14%, 2 year survival 72%, 5 year survival is 56%, and 10 year survival is only 35%. So this is the kind of disease that you're living with when you have HFrEF. But having said that, the outcome really varies significantly with the age of the patient. So as you can clearly see, if you're older, you do, I'm sorry for this busy slide, but it depends on the age. Obviously, the older do far worse. It depends on in what settings are you treated. Whether this is the one is treated in a primary care setting or you're treated in a proper advanced cardiology setup. Your survivals are much better if you're treated in the secondary and you get the right therapies. And it also is dependent it's also dependent on the correct therapies that you get. So heart failure, if you see, has poor survival, and it's been quite remarkably compared to actually small cell lung cancer, which is, we all know, stage 3B, advanced non-small cell lung cancer has almost similar prognosis. So it's far worse than most common cancers and is as bad as one of the bad cancers to have. So heart failure has poor survival. What about the Indian data? So our, unfortunately, is quite bad. This is a study from InterCHF, which we did from India, and there were several centers from within India, and you can clearly see in this patient with there were about 900 odd patients from India, and you clearly can see that after Africa, we did the worst in terms of 1 year of mortality as compared to other countries, which were all from the low middle income countries. There were no high income countries in this. And the reasons being was that we didn't use enough of what all Dr. Mohan said in his talk. There was low use of beta blockers. And if you see most of the people, even if they got less than half dose of beta blockers. And so people getting more than half the dose were just one third got beta blockers, ACE inhibitors, and just a very small amount of them got the MRAs. And this is clearly seen in outcomes as it's seen in this Trivandrum heart failure registry. If you get guideline therapy, mediated therapy, or you get all the three optimally dosed drugs versus if you don't get, your survival is twice as much as those who do not get this therapy. So as I said, your prognosis or your outcomes of heart failure depends on whether you get the right therapies or not. So this is just a summary of all the studies from India with the InterCHF, Asian Heart Failure, Trivandrum Heart Failure Registry, and the three large ongoing studies which you should know about: the Kerala Heart Failure Registry, the Global CHF, where we have recruited almost 2,500 people from India, and the National Heart Failure Registry, which we have just completed with 10,000 patients, which is an acute heart failure registry. So what do you see? As in ACS, as in CAD, you see our patients are much younger, almost a decade younger as compared to the two Western studies which are mentioned here from Europe and US. So our patients are younger. They have less atrial fibrillation because probably some of it because of the lesser age. And the in-hospital mortality, if you see, is much higher in ADHF trials, almost 2 times as that in the Western population. And long-term mortalities from THF, Trivandrum Heart Failure Registry, if you see, there is 5-year mortality was 60%. So obviously very poor outcomes once you diagnose heart failure. But as I said, you can largely modify the outcomes, and this has already been discussed, so I will not go into details of this, but this is all the gamut of things that we have in our armamentarium now, which reduce mortality. We're not talking of soft endpoints. ACE inhibitors, ARNI, beta blockers, MRAs, hydralazine, isosulfide combination, ICD, CRT, and mitraclip, and now SGLT2 inhibitors can be added to this list, which have now all shown potency to reduce mortality. And when we combine these together, just these 3 drugs together, ARNI, beta blocker, and MRA, we can reduce mortality of heart failure by 63%. And even if we are not able to afford ARNI, which may be a case in our settings where we practice, especially patients who do not have, for example, health insurances. If you just give these 3 generic drugs, ACE inhibitors, beta blockers, MRAs, you can reduce mortality by over 50% to the tune of 56%. So it is, I would say, criminal negligence not to give these 3 drugs to all heart failure patients and not to optimize their therapies. So this is something which you have to have a takeaway. Must give these drugs, give them early. And as it was said, instead of the vertical approach, increasingly there is a more of a horizontal approach. That is, you introduce, instead of going for maximizing dose of one drug, you go for low doses of all the classes of drugs that you can offer to the patient, and very quickly then as tolerated, up titrate the dose of all these drugs. So even sudden cardiac death, actually, this is an analysis from the Glasgow group showing that, remarkable reduction from early days from a trial in 1995 rails to the more recent paradigm. You can see how the sudden cardiac death, annual sudden cardiac death mortality has come down from 8% to 4%, not by using ICDs, but by using the modern therapies, and they're very provocative in saying that using optimal medical therapy might negate the use of ICDs in these patients. So that is the power of modern therapy, and that is how you can alter the epidemiology or the prognosis of heart failure patients if you treat them correctly. So that's all I have to say. Thank you so much, Mohit, Girish, and CSI Delhi for giving me an opportunity to speak.
Thank you so much, Dr. Ambuj. Thank you so much, Dr. JC Mohan, for excellent talks and great take-home messages. Over to our panelists, Dr. Neeraj Palla, Dr. Ashwani Mehta, and Dr. Vimit Jain for the questions that have come and for any comments and any things that they would like to talk. But it was really a pleasure and a treat listening to both the speakers, no doubt.
Dr. Mohit, my request to Dr. Ambuj Roy to have made the diagnosis a bit simpler for the postgraduates, because there is so much of data which he presented. It's nice to look at the slides, but once you have to remember it, then it becomes a very difficult proposition, right? And I think the ESC definition of heart failure, that gives the comprehensive symptomatology, structural changes, as well as the pressure changes. So that simplifies the whole thing. But this is one thing. Then secondly, the mortality benefit which the EMPEROR trial and the DAPA-HF, in the EMPEROR, it's primarily the mortality benefit is not there, which we have seen in the various slides, that it improves the mortality benefit. Is there? Mortality benefit is driven by the heart failure hospitalization rather than this. So I think this needs to be really clarified once we take these things to the clinical practice.
Yeah. So yes, I think the residents have a much better memory than us and can go through those slides. But yes, as you rightly said, ESC is a more modern way of diagnosing heart failure, and it has the three conditions: the clinical conditions, the symptoms, and any ECG change, and then you rely on natriuretic peptide to make a diagnosis of heart failure. Obviously, we are not talking of ADHF here. We're talking of a patient who comes to your, and maybe like a 55-year-old elderly obese lady comes with dyspnea, whether it's deconditioning, whether it's some COAD. So there is the challenge of making the heart failure HFpEF versus just deconditioning. So there is where the algorithm will work, and where you need to do that exhaustive workup for diagnosing HFpEF, because if we diagnose and treat early, we know we can change the time course of the disease. As for the SGLT2, you're right. DAPA-HF did show a 17% reduction in mortality. EMPEROR reduced did not show that. But I still think they are excellent drugs, and they will be part of the armamentarium as we go forward in management. Whether this is a chance thing or a molecule specific, I think it's more of a chance. Both of them are showing a similar combination, combined endpoint reduction. So yes.
One more question. It's related to the same thing. That is, we have a patient with low ejection fraction. He is symptomatic, but the BNP is normal. Then what do we do, and how do we classify these kind of patients? And what is the line of management for such patients? Because we see these kind of patients quite well, quite often in the practice.
So, if it's HFrEF does not rely so much on natriuretic peptide for diagnosing it. It's the HFpEF where you need the natriuretic peptide. So even if it is symptomatic HFrEF, and where you diagnose LVEF less than 35%, even if it is symptomatic, we know that beta blockers, ACE inhibitors will help these patients, and they should be on those therapies. If they are symptomatic, then of course we can use the entire armamentarium of heart failure medication. I think natriuretic peptide is in HFpEF, but it's been said that even up to 20% of HFpEF patients in studies have shown that they may have normal BNP levels. And that has been, especially if they're obese, is something where obese people do not have the levels of rise that happens in of BNP that happens in non-obese. So there, natriuretic peptides may be a problem, where you have to then rely on other eco criteria. That's why I mentioned the HFrEF criteria, which is very objective in some ways to diagnose HFpEF.
Thank you.
I think we can take some questions from the students.
Yeah.
One of the question, Dr. Amboj, is regarding the use of SGLT2 inhibitors in elderly population. Can they be given?
Dr. J.C. Mons would love to answer that.
So both trials, Emperor Reduce and DAPA-HF, had the lower age limit of 18 years and above, but no upper age limit. So the answer is very clear that there is no upper age limit for giving SGLT2 inhibitor. That is in randomized trials. Low battery. But in practice, remember that these are the drugs which actually have caveats. These cannot be at the moment given to patients who have hemodynamic instability, who have hypovolemia, postural hypotension, relatively low blood pressure. And of course, we also are aware of the fact that some of the studies, the fractures have been more common. Having said that, you would have to use your judgment, but the guidelines would come, and we'll come to know of that. But looking at the two trials, there is no age limit where SGLT2 inhibitors cannot be used.
So there is another one of the practical problems that we face. We get a patient of class 2, class 3 heart failure who has a blood pressure of maybe around about 100 millimeters of mercury, and he is to be started on the heart failure therapy. And often we see that when we introduce ARNIs to these patients, there's a significant drop in the blood pressure. And as you have advocated the sledgehammer approach for these patients, so how comfortable would you be, advocating all the therapies simultaneously along with the diuretics to these patients?
So the sledgehammer approach comes from the PROVE-HF study, where 50 milligram BD or 200 milligram BD at the end of 1 year caused same improvement in ejection fraction, exact 9.4%. So the point I want to mention is that in case you have a lower blood pressure, nobody says to start with 50 milligram twice a day. You can even start with 25 milligram twice a day. And maybe you can take a day or two. Eplerenone certainly does, and even spironolactone do not reduce blood pressure or reduce by 4 or 5 millimeter, unless of course hypertension is present. I don't think beta blocker, especially bisoprolol or bisoprolol especially, does not reduce any blood pressure. My tendency is to use these drugs as quickly as possible. May not be same day, maybe in 2, 3, 4 days time. ARNI is a big issue, and the issue is nearly a quarter of the patient would not tolerate any dose of ARNI, 25% in practice. In trial, there were 15%, 14, 15% patient in paradigm-HF. In practice, they wouldn't tolerate. However, if they don't tolerate, you have to move on. You have to use SGLT2 inhibitor, you have to use beta blocker, you have to use MRI, you have to use evablend. And maybe some of these people who don't tolerate ARNI may have to be given ACE inhibitor. But having said that, people who draw maximum benefit out of ARNI are those who develop hypotension on ARNI. So keep that thing in mind.
If I can just give a sort of practice guideline that I follow. If you look at how the paradigm-HF trial was designed, there was a run-in period for 2 or 3 weeks of patients who could tolerate ACE inhibitors or ARBs, following which ARNI was introduced. And as we are all now trying to give ARNI to all our patients, we all realize that hypotension is a major problem for many of our patients, and we are limited by, like you said, either not being able to initiate ARNI at all, despite our best intentions, or we are not able to up-titrate the dose. So one of the ways that I follow is to try to give a run-in with an ACE inhibitor or an ARB, and if they tolerate, then maybe these become candidates. This is one way that I felt might be a good way.
It is quite acceptable. It is quite acceptable. The other trick is to use half the dose of what you recommended. Actually, the dose recommended 100 milligram BD unless EGFR less than 30. We never do that. We start with 50 milligram twice a day. But in a given situation, as Dr. Mohit said, 100 blood pressure, I am comfortable starting with 25 milligram twice a day, and we are able to build up. But blood pressure alone is not the problem. I have a good number of people who continue to have 80 blood pressure, but they are walking around and no great symptoms, except while getting up, they have a little bit of giddiness. These people eventually would benefit with the drug. So we are evolving our own ways of giving ARNI, sustaining ARNI, and you are absolutely right. It's not a bad idea to have a running period where ACE inhibitors can be given to some extent and see how are they tolerating. There is no doubt, but ACE inhibitors are tolerated better than ARNI. There is no doubt about it in our practice.
Yes.
In fact, I like to make a point here. If you look at the tolerance levels, ACE inhibitors versus ARNI, in fact, ACE inhibitors, ARNI, what Dr. Mohan made a point, using half the dose, most of the patients would be able to take that. And you need not be in a hurry to increase the dosages. If the blood pressure remains low and the patient is asymptomatic, maybe even after a few weeks, you can try and increase the dose. And it works in most of the patients. And even in this trial, I was a part of Paradigm HF. So there was a provision that even if you have updated the dose, you could down titrate the dose. And you'll be surprised, in many of those patients, we had to down titrate. Some of them had reached 200 and then they had to come back to 100. And there was a significant percentage of patients. But then whatever is the dose, and I'm sure even with 25 milligrams, the benefit is seen. Due to the
I would like to take a little exception to this.
Yeah.
Sorry. Can I? Sorry, please, Dr. Ambud, go ahead.
My point is that yes, ARNI is a great drug, but Paradigm only ran in those people who tolerated 20 milligram of enalapril and 200 milligram BD of
beta blocker,
ARNI.
metoprolol.
So, at 25 mg BD, we don't have data. We assume that it will help. So there are limitations.
Obviously.
Very realistic thing which Mohit has said. And I think there are more than 25% people who are not able to get ARNI so that is the message that you should take from here.
Yeah, exactly. And in fact, in these patients, we can give them the other drugs, SGLT2 inhibitors being one of them. The advantage is, so it was a wonderful talk. And in fact, both the speakers have done a great job in elucidating, and Dr. Ambujrai also summarized the guideline-directed medical therapy in the end. In fact, 2 points I think need to be mentioned here. One is the role of iron therapy, because we know that the iron therapy has been one of the very important areas which is neglected and which has a direct result, and the another being the vaccination, especially now in the COVID times, and that has also shown improvement in the heart failure. But overall, wonderful talks by both the speakers. In fact, it's a great learning for everyone, whether it's a PG student or a physician or even all of us sitting here.
I absolutely endorse that. I absolutely endorse what you said. Wonderful talks by both the speakers. Really enjoyed and learned a lot.
So there's another question here that do MRAs, this is by Dr. Kanhai from Manipal, do MRAs cause more hyponatremia at higher dosages?
I don't think so. I don't think so. We haven't seen it.
Yeah.
I'm a
Again, sir, on the same issue, what exactly is the dose of MRS? There's a lot of confusion with the residents as to what is the mortality, what is the dosage of MRAs, at which mortality benefit is seen.
The mortality benefit is a 25 milligram whether you use spironolactone, eplerenone. Higher dose produce no additional benefit.
Yes, rails clearly showed that too. And for eplerenone, there'll be 25 to 50. For spironolactone, I think 25 would be 25 is more.
What about this low sodium potassium chloride salt replacements, as a replacement for the routine salt, table salt?
So take a crack at that. Actually, this question is asked every time I'm in a
yes.
I don't know what is the sodium content of that salt, what is the potassium content of that salt. If the sodium content is lower than sodium chloride, common salt, you can be a little liberal. But the pure study actually tells you how much sodium chloride you can take, and proportionately you can decide how much of this rock salt or the other salt you can take, depending upon how much sodium is present.
It's 50-50, sir. It is 50-50, 50 sodium chloride, 50 potassium chloride.
I would be worried about potassium because if there is an issue of patient being given MRA,
CKD.
creatinine level is high, I would be very much worried about that potassium part.
I will resonate with you, and just to add, not to increase the discussion on this salt, I would just say that only yesterday the complete meta-analysis review article on the salt in hypertension and heart failure in European Heart Journal has been released with a beautiful editorial. So it's a worth a read, and they very nicely summarize everything. And the evidence is not, they again come with the same conclusion and the same arguments that we are carrying out here. So the evidence is not very robust. And let me tell you, there's no study which has compared the types of salt, whether it is a potassium or a sodium rich. There's no head-to-head comparison whether the rock salt is beneficial or this particular salt is beneficial. And the last evidence that I reviewed was that you cannot score one particular salt over the other. So I would strongly recommend all the residents also to read that article, only released yesterday in the European Heart Journal. It's a beautiful meta-analysis and a review of the all currently available evidence. How do we treat the diuretic resistance if we see while managing these heart failure patients? One of the residents is asking.
So let me take a crack at it. First thing is you have to define diuretic resistance. Multiple definitions are available, but the important thing which people say is if with an intravenous dose of 40 milligram, you don't produce 400 ml or more of urine, then it is diuretic resistance. That is a very simple way of putting the things. You can have many ways. People, despite the optimal dose of diuretic, remain congested. You can call it diuretic resistant. How do you manage? Do what is called sequential nephron blockade. Give drugs which work at PCT, DCT, proximal convolutive, and distal. Even tolvaptan, the drug can be used. So a sequential nephron blockade is the best way. Some people have suggested that instead of oral, give to IV, instead of doses, go to infusion. I think the dose study has clearly, and unload studies have clearly said these things are not very effective. My way is sequential nephron blockade. Having said that, please try to find out the cause of diuretic resistance, which could be NSAID, which could be steroids, which could be drugs like pioglitazone. There can be, it could be licorice. There can a lot of the so-called teas, not green tea, other kind of teas. Many reasons for diuretic resistance. But having ruled out all those things, do a sequential nephron blockade.
Another thing, sir, which has been given is that you give salt to these patients, so they become salt sensitive, diuretic sensitive, and so salt. These articles are also coming up now that this is the blockade of the receptors which occur with the repeated diuretic usage, and you give salt to these patients, they become again diuretic sensitive.
So thank you so much, sir. This was an excellent interaction and wonderful, data given by both the speakers. And if I'm to summarize in a couple of lines, Dr. Ambuj nicely summarized that for residents, what is the conservative estimates of the prevalence in India is approximately 1.3 to 4.6 million, and the percentage increases with age. And we must know that how heart failure in India is different from heart failure in West. More younger population, more CAD, more severe disease, less atrial fibrillation. So you can go on, and that beautiful slide in which you summarized all the currently available evidence. Let me tell you, if you have missed it, don't worry, it will be available on the YouTube channel of Delhi PG Track Delhi CSI. You can catch hold of that slide and again read that data. It was excellent to have those numbers from you, Dr. Ambuj. And Dr. J.C. Mohan, as usual, you're always so candid and so good in your delivery with the wonderful slide. And every time we listen, we gain something new. So it was not only a PG Track program, both these speakers have given a lot of new evidence for all the practicing specialists and the cardiologists also. Given the limitation of the time, they did absolutely more than justice to their talks. And thank you so much for joining us this evening. And my dear friends, I would like to say that in case you have any other questions and comments, please write to us on pgtrackcsi@gmail.com. Any particular sessions, any comments you have, we would be happy to conduct those sessions for you. Next week, again, as usual, we are back to our 27th webinar on the Thursday evenings, 6 to 7. Please note 6 to 7. And we will be having Dr. Prabhavati from Jayadeva speaking on dyspnea. last week we have a session on chest pain, which was a phenomenal talk. Next week we are again going to address on dyspnea, the cardinal symptoms of cardiology. So I must thank Dr. Ambuj Roy, Dr. JC Mohan right at the outset, and heartfelt thanks to Dr. Ashwani Mehta, Dr. Neeraj Bhalla, Dr. Vimit Jain, Dr. Amitesh, and my colleague Professor Girish MP for joining us on this beautiful journey. It was a great learning, and thank you Intas for supporting this program, and we'll catch up next week again at 6 p.m. on Thursday. Hope to see you all next week. Till then, goodbye.
Thank you.
Thank you.
Thank you so much.
Thank you.